this echo is just starting with the partnership with Stratus Health and the MAFP, really going back to get people up and going with now with MOUD, medications for opioid use disorder, versus the MAT, and increasing access for patients.
Yeah, it's for those of you who don't know, it's for both family medicine and addiction board. Addiction board almost, I don't know, 2 years now. And
actually moving into more of an addiction clinic here in the near future. So
we're also going back to primary care.
so,
So kind of the way that this will work is you'll get announcements like this, and then you gotta talk closer to the microphone. Then we'll do a didactic every time. We do have a couple friends that'll do some of our didactics for us, and then we'll do case-based learning at the end. So we will start sending out a form. So if you all have cases that you come up with that either coordinate well with the topic or just anything that might be complicated. So a patient that you're thinking about starting on Suboxone, or a patient that might have an opioid use disorder, or who maybe has high morphine equivalents or anything complicated, you can send it in, and then we will kind of utilize this whole ECHO network and brainstorm different things.
yeah, we often don't have the answers, but somebody on here may chime in with an answer as well. So just so you know, next week it's going to be a talk on urine drug screens.
2 weeks.
2 weeks. In 2 weeks will be urine drug screens. If you have particular cases that are interesting with their urine drug screens, anything like that, that's something you can sure get to us as well. So, all right.
When we say urine drug screens, it's pretty in depth. We can make it last than almost an hour.
Yeah.
So, if you all have questions as we talk, please chat them in. We're pretty good at addressing them. Otherwise, at the end, of course, or interrupt us, raise your hand, all the fun features. Again, we're pretty chill, so don't feel like you're going to be offending us.
Yeah, and just so you know that today we do not have a case. If we don't get cases from the crowd, then we often will come up with cases of our own. So again, feel free to reach out to us if you do have a good case that you want to chat about. So it's always fun. All right, so Heather's going to bring up the talk, and then we're going to kind of get moving. Can everybody see the talk? Perfect.
Oh, we're so good at getting.
That was pretty good. We have no IT. We have no team. It's just us. So we're winging it.
We have a lot of team members at Stratus and MAFP. They're just not in a room with us, and we like to have control on our own slides.
So medical comorbidities. So we're going to touch on a few different objectives, talk a little bit about some of the how to differentiate the medical diagnosis that increase the risk of taking opioids, some of the medications that increase the risk of taking opioids, and then medical complications that can occur if a patient's on chronic opioids. It's a lot to pack in, but they're kind of some fun topics.
Do you want to start?
Go ahead.
Okay, so mental health. So a lot of things with opioids and people who have mental health. And the biggest mental health diagnosis that we should all be aware of when a person is on chronic opioid therapy is depression. And so increased risk of death, especially if you have those higher morphine equivalents. And it is very hard, though, to know, was this an intentional overdose or was this an unintentional overdose? So that is something we all have to be aware of if you have patients who have mental health diagnoses, especially depression, who are on chronic opioid therapy.
So let's get right into some of the different things with substance use disorders. I think that the important thing to understand, and all of us see patients with all kinds of different substance use disorders, these patients as a whole, taken as a whole, are 2 to 4 times more likely to overdose than patients without a history of any substance use.
So it's important just at the outset, all these patients that we see with any type of substance, whether it's alcohol, whether it's opioids, these patients are at high risk. We always have to think about that.
It doesn't have to just be one. Now, Kurt, you are echoing. Okay, so benzodiazepines, and this is something that as physicians, we all got the letter that talks from the CDC and from the state. Is anybody else getting a lot of feedback? A little bit, we can kind of lean in then more. We need to get a microphone, you guys. This is just a new setup and we're used to apologies. Well, I definitely address it for in 2 weeks. Okay, so benzos co-prescribed with opioids, a significant history of overdose risk, even if people are taking it correctly. So it's not even always an intentional thing or a street thing. And you can see that 31 to 61% of deaths have this co-occurrent benzodiazepines with opioids. And you can see on the graph on the right that the higher the morphine equivalent of the opioids, the higher the risk of overdose deaths. And for those of you with the CDC guidelines and the state guidelines, they recommend no higher than 50 morphine equivalents if they're also on a benzo. So you can see that right here. And all the prescriber report cards we're all getting, this is one of the studies that came from. So the most common, of course, we just said was the opioids with the benzos. The patients with alprazolam and oxycodone, those two medication combinations is 10 times greater risk of death than a person not taking either of them. And this is one of those statistics that makes you really kind of shocked. And so we're going to kind of hit that home a lot throughout this series, is watching co-prescriptions, but this is one of the big ones.
Let's talk about alcohol. Why don't you talk about it?
Oh gosh, it's only because it's complicated. Okay, so you can all see here on this wonderful cartoon liver that this is the breakdown of alcohol, and you can see this microsomal, the MOUD, we'll just call it that. It's one of the breakdown areas of alcohol in the liver. Opioids, to some extent, are also metabolized by this hepatic MOUD system. So together, they actually augment this. They kind of make this process happen faster. That is one of the thoughts in tolerance building. So people can drink more over time because it's breaking down faster. This is one of the reasons that people believe in tolerance. However, if you're on both alcohol and opioids, it actually slows this down. So if you're slowing down the breakdown, you're going to have a buildup of the actual active components and therefore increased chance of toxicity, overdose deaths. Also, alcohol can modify some of the opioid receptors. And if you're looking specifically at methadone, whether it's from a methadone clinic in OTP or the prescription pill form of methadone, together, this patient population does have a much higher risk of having alcohol use disorder, and that's believed to be related to those receptors as well as the breakdown through that MOUD system. If you look just straight at alcohol, how much is also prescribed or how much is also found in patients who show up to the ER. So when people get brought to the emergency department, whether they got Narcan or they came to the ER because of opioid-related things or benzo-related things, you can see how often alcohol is also in their system, especially at time of death. So overdose first, you always got to be careful in knowing that there's alcohol there. And that can also be important if a person is withdrawing from opioids. One of the favorite ER cocktails historically has always been to throw a bunch of benzos at them and kick them out the door because they're in opioid withdrawal and they're erratic. It's not necessarily the best thing because now you're giving them yet another sedative. If you're admitting a patient because of complications with opioids or overdose or infections related to opioids, you always have to, in the back of your mind, think about alcohol being there too, because they're obviously at higher risk of having alcohol withdrawal in the hospital, which might be, covered up by some of the opioid withdrawal. Definitely something you don't want to create an alcohol withdrawal seizure with by not paying attention or remembering that alcohol is potentially there as well.
Yeah, so, the other thing to think about alcohol, ethanol and oxycodone, actually, I think we have to understand first that people do drink a fair amount of alcohol and they may not tell us a lot about it. And I think that's, especially when we're prescribing anything for pain, whether it's acute or chronic, we have to have that conversation because when you look at ethanol and oxycodone, they cause a greater ventilatory depression than either alone. And that's pretty much common sense, right? But this magnitude of that is very clinically relevant. And again, when we look at the elderly population, and by elderly, I mean much older than me, maybe 80, 90, anything older than me. But the elderly are much more affected. And we're going to talk about that in a moment, the reasons that that's a little bit bigger of an issue.
You'll notice that every year it gets older.
It gets older. And one of the really interesting things first is that this major concern with alcohol and opioids
is something dose dumping. And this is something that I had not been familiar with previously, I hadn't really heard of for a long time. But dose dumping is an interesting thing that happens with some of our long-acting opioids, the ER type ones and the CRs. That you get, unfortunately, when you mix alcohol in with these long-acting pills, often you get this very unintended rapid release of almost all of that in a very quick, as you can see on the slide on the right, that you can get this dumping of the CR dose very quickly. And this has been linked to many overdose deaths when people who are taking opioids suddenly have a couple of highballs, and the next thing we know, they're asleep or they're not breathing. So again, the biggest results of mixing these two are increased overdose and increased abuse potential. The funny thing is, it's kind of like before fentanyl was common, when people that we take care of would find out that a certain dealer had fentanyl, everybody would find that person, right? Because they go towards the thing that might be the better, kind of a better experience. And so the same thing has really happened with this, is that people take these and then will drink knowing that they're going to get this dumping and that intense high. So understand that people not only do this accidentally, they do this on purpose.
Yeah, patients are way smarter than we are.
Yeah, they
I
know.
do want to comment on the highball thing, because who drinks highball?
Yeah, that's an old term.
Exactly.
And again, alcohol, if you take one hydromorphone ER capsule and you mix it with alcohol, you get a 16-fold increase in plasma concentration. So again, think about somebody that doesn't have tolerance, and they suddenly take one of these and then have somebody come over and they have a couple of beers, and here we go. And so it can be a really interesting problem. The mechanism of this is very poorly understood, but we know it happens.
I think now that I know for sure there's 2 geriatricians on this call, if there's not more, but obviously family medicine, we take care of a wide range. This would be one of those, whether it's Dilaudid capsules, which I've never even thought to prescribe, or even like an oxycodone or any of those long acting, which when I was in training, which wasn't that long ago, that was when everyone said, oh, get everybody on long acting because they have lower abuse potential, less euphoria. So we still do have a lot of patients on the long acting, and then maybe some breakthrough short acting. And if they're on that and then they do have a drink at night or whenever, that could be an unintentional overdose. So something to definitely think about, especially as we all know that the amount of alcohol people are drinking is not always fully disclosed. Okay, I got to do cough syrup because it's my favorite topic. Okay, cough syrup. We had a conversation about this yesterday. We did put this on our podcast today, but coating cough syrup, any of the controlled cough syrups, even the FDA says there's literally no benefit to being on these, and it actually definitely has a ton of risk, especially in anybody who's not an adult. It's just not supported. So, I've seen patients that I acquired with retirement who had refills on cough syrups, a whole year's worth of refills, and there's really zero benefit, and there is a ton of risk. So there you go. No benefit. And this was even way back in year 2000 before I had graduated high school. Anyway, so I put this whole thing on here about cough syrup versus honey, because this is kind of, again, one of my favorite topics. Cough syrup is just definitely not beneficial. If you look at the American Lung Association, once again, no good evidence about cough syrup. And when you look on this study on 270 kids, which is quoted quite a bit, and there's other studies that are ongoing and other studies out there as well, kids who received honey actually had less coughing, less severity, and clearly more safety as long as they're over the age of 1 than anything else. And there's other benefits to honey, which I'm not going to go into holistically, but there are benefits to honey way far outweighing the risk of the coating kind of cough syrups. Plus, coating cough syrup, any cough syrup, this is a huge a divertible medication because it has a ton of street value. Especially, you'll have people come in and say they don't want the flavored kind because the flavored kind actually doesn't taste as good. So they'll want the completely natural, non-flavored, brand new bottle, no coloring, because then they add fancy things to it like soda, Jolly Ranchers, sometimes wine coolers, because why not? And then you'll hear all these fun slang things. Purple drink, scissor are the ones that I hear the most, but it's a pretty drink, which of course, then if you're thinking about kids in contact there, that could be a huge deal.
Yeah, it's interesting too that I think so many patients that I see for opioid addiction have done this in their high school and college years. So I don't think it's rare. It's a very, very commonly known thing.
There's a question I'm going to go back to only because it's on the dose dumping. Is it thought that the increased release of opioid from tissue as it's moving back and forth to find the steady state, or do we think it's related to the tablet degradation and the release itself? Everything we can see, it speaks more closely to the tablet degradation and the release itself, just from the formulation, because the closer they drink the alcohol to the time they take the capsule or tablet is when the higher peak of that dump would be. But there's still other mechanisms that they are looking at as far as, is there other contributing factors, which might be like this tissue steady state idea.
Yeah. And I think the important part is that you have
A conversation with patients when you give them any kind of prescription, even for acute, that's how important it is. Because anytime we get these older patients, especially when they're on a long acting, boy, we can really have a problem. Soma. Now, in my age group, Soma was a very commonly used medicine. A lot of the younger people may not have used this much, but 15, 20, 30 years ago, this was a commonly prescribed medication. And I would have to say now that even some of the work that we do at the state, that state looks at Soma as not their favorite medication.
Okay, can I just say one disclosure?
You can.
We totally we're using the name brand of this because can't say Kira's soap or doll. Soma's easier. So we do realize we're using a name brand.
Yeah, it's really hard.
But one of the things we talk about Soma is because of the combination, and some of you may have heard of this, but this is a very common thing when people mix opioids, typically oxycodone, alprazolam, and Soma. And in fact, there are cases where patients or people make this, they mix them up in a big bowl, crush them, mix them up in a big bowl, and then make tablets. We've had patients who have their own tablet makers, and they will make tablets of what's called the Holy Trinity. And this is a very common thing. If you ask anybody who's used heroin or fentanyl whether they know what the Holy Trinity is, everybody knows. And it's that combination. It can be very addictive, and the respiratory depression, especially if you're out and you have a couple of drinks with this, you could really have trouble. Remember that the major metabolite of Soma is actually meprovamine, which is also had been a prescription drug that I don't know that I've ever prescribed that. I don't think ever, even in the old days, but it acts much more like a barbiturate than anything else. But understand that this is a combination, and we have done chart reviews where we've had patients who are getting all three of these medications, and you know right away what's probably going on. You generally have a physician kind of in my age group who's comfortable prescribing Soma. And the patients often will ask very specifically for other things, and these are the Holy Trinity.
And not to say that opioids with other benzos and Soma together is also not, requested. It can be there. It's a common occurrence that someone might end up on all three accidentally by a person who doesn't necessarily understand the combo.
The Z drugs. Let's talk about sleeping pills, because sleeping pills and opioids are an interesting problem. I think if you ask most physicians whether there's a black box warning to use things like Androgen and other sleeping pills with opioids, I don't think most people really pay attention to that. I think that often if we look up something in Hippocrates or any of these different types of things we have on our phones, boy, if we see a black box warning, we're like really taken aback, and boy, we really read carefully whether or not we want to do that. But when you think about how many people are on sleeping meds and also on opioids, it's pretty big problem. And so obviously adding these Z drugs to the opioids increases your risk of unintentional overdose by nearly 4 times in that first month. And so generally, until they build up some tolerance, that first month is very dangerous. So keep that in mind. This is a black box warning. Obviously, the state and the opioid work group is looking at this, and you're getting report cards that
that will tell you that they don't want this to happen real often. And so just understand that it's that first month is really risky.
And one of my biggest pet peeves is no female should ever be on more than 5 milligrams of Ambien anyway, which is clearly not, people are on it. And we'll explain some of the sleeping issues with opioids and why this is sometimes happens coming up here in a minute. I'll talk about age. So again, the elderly definition. I was going to throw a poll in here to have y'all guess how old he is. I mean, he's got a booster and a shake in front of him. He drinks them regularly. But anyway, so yes, but the biggest thing is falls. There's so many risks, as you all know, with just the changing in body composition and all of that as you grow older, metabolism changes. And so NSAIDs, yes, they have their own complications as well, but the falls are going to be huge, especially with the fractures. And even in that first 14 days, I mean, that risk of fall is humongous. And so, really watching that limiting of prescription length, and we will get to that at some point, but that days 3 to 5, if you're going to do an acute prescription, is really kind of where that limit should be. Just the falls. And I always think of orthopedic surgeons, they do this big joint replacement and they might need a longer pain medication, but they leave the hospital. And if they're felt safe to go home, are they really? They have 2 reasons now to have falls. And are they going to be right back in getting their next hip done in another week? And I think that's what happened to Kurt.
Often when we review charts in the past, if you have somebody who has taken opioids and is falling, clearly you have to intervene. You have to do something. The other thing that I often think about that's very similar is if you have people with accidental overdose. So it's really these 2 things. If you see that in a chart that somebody's had an accidental overdose or they've had falls, this is something that you always have to address and make sure that this patient probably is not a candidate to be on these medications from a risk standpoint. And so, just keep that in mind. I had some chronic pain patients, probably 10 or 12, not a lot, but I think you have to be monitoring them. And the key is if something does go wrong, you really have to act on it. So I think that's really the important thing.
Okay, so other things to think about, and this is kind of what I was alluding to, is the decreased distribution, the liver metabolism, renal excretion, all those things. They're also on a lot of medications, whether they're one of the medications we already talked about or, all the other gamut of medications that do impact metabolism and could potentially cause one of these, combination trouble. Definitely things to watch for. And if they're on other medications, are they going to potentially forget that they took this one? Are they going to double take them? Is it going to, they're on a different one that might increase their risks of falls, and now you just put them on another one that can increase their risk of falls. So it's just definitely something to watch for.
And the other concern is the effect of aging. It says cerebral wall decreasing.
I don't feel like mine has decreased yet. So
that's why I'm here, but it also says in here, but it's kind of small typing, percentage of function at 75 to 80 years of age.
Oh, perfect. So
compared to a 20-year-old. So.
Much older.
Okay. And again, when we're talking about alcohol mixed with chronic or acute opioids in the elderly, we just talked about that combination, and now we're talking about changes in metabolism and all the other health concerns in polypharmacy. And so when you talk about respiratory depression, it's even just in general worsens as we age.
Ooh, lung stuff. So remember patients that have COPD, okay? And this is really, really kind of a controversial thing, because I think often when we get the patients with severe COPD, the thinking always was when I was, in my practice doing mostly family medicine, is this shortness of breath and how sometimes the things we use to help their shortness of breath. But understand as well that if you take all the COPD patients out there, half of those patients are actually on opioids for chronic pain anyway. Now, and they may not be short of breath, but they're receiving opioids for other things. And again, I think that's something that we have to look at and we have to address when we see these patients. There was there have been big studies. This one was actually in the International Journal of Obstructive Pulmonary Disease, where it talked a little bit about adverse outcomes and that opioids are clearly related to the adverse outcomes and really shouldn't be given to these patients, without really thinking about it. Again, it has to be a well thought out process because there's clearly risk for this. And if you look at this Canadian study, it was kind of interesting that 4 to 10% of the Canadian population has COPD. Okay, the 5-year mortality of patients who just have COPD is 40 to 70%. But if you put those patients on opioids, their 2-year mortality is 50%. Okay, so clearly something's happening there. And so we know that they're much more likely to die, and their risk of death is much higher if they're on opioids compared to the people who are not. They also have increased ER visits, hospitalizations. They get a lot more antibiotics and steroids. And there's actually, in this study, it's interesting because I'll show you the next study as well, there's some evidence it wasn't really dose related. And so it didn't matter how much you were on, your risk was up. Now, this is another study out of the European Respiratory Journal, and it talks a little bit about evaluating risks of adverse outcomes associated with the incident opioid use. So patients that are started on opioids, and this is actually a huge study. It was a very big study. I think it was over 100,000 people. And basically it was 130,000 people. They took patients with COPD and opioids. And they pointed out that there had been previous studies that had shown that high dose opioids were associated with all-cause mortality increase, right? But this study actually was the first one to link make the link between opioids and respiratory-related morbidity and mortality, regardless of their dose. And so again, much like the other study where they thought potentially how much they were taking wasn't going to make a difference, their study clearly showed that even low dose can decrease their mortality.
Still the same study. So the final point in that same study is that, was it dose related? Well, no. But what about the severity of COPD at baseline? Because even on the other study, when that one was the first one we reviewed, it was like, well, the 2-year mortality was in patients with severe COPD. This study showed that it really didn't matter what their baseline severity of COPD was. It's a combination of the COPD with the opioids. So sleep apnea, this is another one of my favorite topics, is sleep apnea and sleeping disturbances. It is, and this is why I had alluded to people who have opioids have a lot of sleep trouble. Central sleep apnea is a huge problem in people who have been on even a shorter course of long-term opioids. So, we're talking a few months to years. We have seen in our patient population who, whether they've smoked or snorted or injected opioids, heroin, any of it, young 20-somethings, thin, no problems, no health problems, who have central sleep apnea related to their opioids. Still studies out there, and as far as does this get better over time? It appears to, especially with treatment, but it's definitely something to think about. So sometimes we send patients, we're thinking, oh, is it just their COPD that they're having trouble breathing at night? Or is it just they can't sleep at night and they have insomnia? Or let's send them for a sleep study. And you will often find it's very important. Anybody who's on chronic opioids, when we used to do chart reviews, what's their sleep studies? What's their sleep studies? Methadone, and this is where we're kind of looking at morphine equivalents again, increases the risk if they're on higher doses, as well as developing sleep apnea, especially central sleep apnea.
Yeah, and there's a question here, but one quick thing about methadone too. Remember that methadone, taken by itself, despite the fact that it's not an enormous amount of prescriptions, has one of the highest risks of overdose death. Okay, so it has a disproportionate number of overdose deaths with methadone. And I think that's always important to understand that, especially in people with sleep apnea. What's the question?
So the question is, how do you suggest palliating symptoms for patients with severe COPD in the last 2 years of life who have failed traditional therapy?
Yeah. Ooh.
Now, I think if you're, referring to palliating and comfort while you're doing all the other treatments, I think it's just something to be aware of, especially if they have other risks. It's definitely part of that shared decision making you're going to have with patients. which is literally anything in medicine, but, explaining the risk, like this could potentially shorten your life because of the respiratory depression. But at the same time, maybe that is acceptable to a patient who's already having such significant breathlessness that they're not having high quality of life. So it's just making sure that the discussion is had.
I think it's probably more important that people with mild to moderate COPD, the risk. The people with severe, there's, again, palliative care is probably more important in that group.
So the two-edged sword of sleep apnea is it can be caused by opioids, central sleep apnea, but then people also who have sleep apnea are at increased risk of complications. If they're dropping hypoxic at night, or what's the other word? I can't think of it right now. They're dropping hypoxic at night and they're already on something else that has the increased risk of having respiratory depression. Their risk of an accidental overdose just from having sleep apnea that's untreated is also there. So it doesn't necessarily just happen one direction. So this is another reason why I think sleeping aids are very scary and can be very dangerous in a lot of patients.
Yeah, and I think especially for the older crowd, especially if they're a little bit heavy, almost all those patients need sleep studies. I mean, we've just found so much of that. But I think I've been very surprised by the 25-year-old, 130-pound patient with previous IV drug user who has daytime drowsiness and doesn't snore and has central sleep apnea. And so again, just be aware of that it's a big thing, and you can really change somebody's life when they get that.
The other thing I want to say about sleep, and this will come up more in our alcohol and opioid, we're going to do a whole talk on alcohol and opioids, is the sleep impact of alcohol. So if patients are using alcohol and opioids, sleep apnea is something we need to worry about, and then being able to educate a patient about the effects of alcohol on sleep is actually super complicated. So we will get to that. So increased risk of arrhythmias and all these other things just with sleep disordered breathing. And now, of course, we're throwing opioids on it. So this is just a huge thing, a study that came out with patients on long-acting opioids with also the sleep disordered breathing.
The kidney changes. This is the short part. Remember that we see a lot of patients in their 70s, 80s, 90s who have chronic kidney disease. And again, a lot of these medications are renally excreted. And so it's important that we look at what particular ones, if a patient actually needs pain medications, what we're giving them, because obviously you can get, really significant problems. Even when we use Suboxone in patients, and we both had patients on dialysis who've been on Suboxone, that actually works relatively well, but some of these things do not. And especially like codeine, morphine with low creatinine clearances, some of these things we have to be very careful with. So just really keep an eye on the chronic kidney disease, especially if somebody's going to need, again, short or long-term opioids, because you can pile it up on them and stop their breathing.
I gotta say a couple things back about the sleep apnea thing, and I don't know if I put the graph in here. Sorry, I'm making everybody confused.
You're giving me a seizure.
Yes. Okay, so I did, and it might be coming up, I just don't remember. When this became a thing with our central sleep apnea and realizing it was a thing with patients who use opioids, we put everybody on Suboxone is the treatment, which we'll discuss, and that does not cause the same incidence of the central sleep apnea for some reason. And there is a graph, and I thought I put it in here, but that is an important distinction. John, I want to address your thing, number needed to harm. So yeah, central sleep apnea incidence prevalence is very low. So obviously this is also low, although I do think it's underdiagnosed. There's a huge substantial population who just haven't been diagnosed, and they're, getting sleep aids, and, you ask them, you're having trouble sleeping. Well, do you snore? Do you, all the typical sleep apnea questions, which don't apply to the central sleep apnea in the same way. So it's just, I agree, still low, but I also think it's underdiagnosed. Okay, so endocrine, obesity, a lot of non-cancer pain, knee, hip, back, lots of things. It is an increase, as your BMI increases, a proportional increase in pain, but there's also as of 2007, they did not have this opioid and obesity association, but that's just a direct association. So again, it's going to be harder to differentiate. Are there other health concerns in patients that would increase their risk or not? Like, do they have sleep apnea or not? And so that's where the risk is going to come in. But it's just being aware that, there's increased risk of pain, not necessarily going to be proportionate to opioid trouble.
Oh, let's talk a little bit about opioid long-term effects. First, immunologic. I think this is something that addiction people talk about a lot because the infections we see in people who are long-term, whether they're using opioids. And this is really a thing because these patients end up pretty sick, they're septic, they get pneumonias. And it's really that effect that it has on your cellular immunity, your natural killer cells, your expression of cytokines, and even the phagocytic activity. So it's really important. And this is something that's been known a long time. I mean, this was first described before 1900 on work that they did in guinea pigs. And this was actually in pain physician in 2008. So understand that this is a group that's going to get infections more, and the elderly, probably pneumonia would be right at the top of that list.
And just like the COPD increased chance of having pneumonias and other hospitalizations, this is, they're already at increased risk of infection already, and this is just going to increase it even more.
Now there's hormonal problems.
Let me talk about this one.
All right, I'll do the last.
We have a little bit of weeds coming in here. So hormonal, decreased total and free testosterone, we'll get to that, that's the asterisk. Also abnormalities in all the other hormones that we all learned about a long time ago. So a lot of concerns. Common ones: sexual dysfunction with people on chronic opioids, depression, go back to the very first slide, also creating troubles, decreased energy levels, osteoporosis is a huge one in women. And now we're going to go in the weeds a little bit.
This is actually one of my favorite topics, and because when we look at patients who are long-term opioids, it's really amazing. This was much of the talk that I give, and I have a whole talk on testosterone and opioids, and much of it, the work was done actually out of a huge VA study. But it's really a very interesting topic. And when we look at what happens to patients who are on opioids over the long term and their androgen deficiencies, it can be very dramatic. And in fact, morphine is one of the worst ones as far as inducing this very dramatic decrease in testosterone. And it actually starts within hours. There's many studies that have shown that within hours of people starting on their opioids, their testosterone levels will start to decrease. And can it recover? In some people, it will recover. Okay. And so I think that that's really an important thing to understand. Just right after it shows there on the bottom graphs that 24 hours after the drug administration, like some of these things will come back. Whereas buprenorphine, it's really pretty interesting how that's.
Yeah, the buprenorphine did not seem to have this is a new article that I found after Kurt had already done this pre-existing talk. That buprenorphine doesn't cause that same effect, and that's going to be related to the receptors in the brain and all those complications. But you can see how quick this can happen. Now, one thing to know is this: that after 24 hours after drug administration, this was after just one dose. This wasn't people who have been on long-term opioids. Yeah.
So it's really pretty amazing. And really, when you look at what happens, the opioids actually inhibit the
hypothalamus production of GnRH. And so what happens then is you just get this, you also get this 5-alpha reductase and P450 aromatase, and you get this metabolism of your blood and brain testosterone that's increased, right? So as that increases, we slowly lose our testosterone.
That's a P450.
That's the P450. And of course, multiple studies have shown this direct correlation between testosterone deficiency and chronic opioid use. There's been a bunch of these, even if you do them intrathecally. So we have people with pain pumps. They can also get this. So don't think that they're somehow excluded from this. So understand that there's been quite a few studies that have shown this direct correlation. There's actually some retrospective studies showing that if you're greater than 100 morphine equivalents, that's probably kind of the watershed area where things are going to get a little bit worse. And it's really not clear how long you have to be on to really have significant troubles, but there's clearly that higher risk if you go beyond a month. But it affects it right away. It can be within hours and in that first week. Is it reversible? That's the question every guy's asking now. It's like, if I was on opioids for this time, can I reverse it? Often normal serum testosterone are seen within days to weeks when they stop it. So they can come back, although, and I can tell you, I've had patients who are in their 30s who were using, IV heroin, and they had testosterones that were completely in the tank. I mean, just completely at the bottom. And we track them for a while before I actually would replace it.
So with that, I just wanted to say I had a patient who had all this fatigue, all of that whole gamut, had a high stress life. His wife had actually died of breast cancer like a year before I met him, but he had this daughter. He got in recovery. Horrible sleep. Did the sleep study, positive for central sleep apnea, super compliant with his machine and everything. Still a ton of fatigue. We had done all the lab work, and then it was like, I never checked a testosterone because this is a late 20-year-old dude, like in the tank. We had to supplement him. And then over time I had to get endocrine involved because we had to kind of monitor him, because the longer he was on the buprenorphine, the more his normal testosterone came back. But it was like a significant night and day difference in his fatigue and his function when his central sleep apnea and his testosterone were both addressed.
Yep. So again, this is from the study that was done with the VA. What the VA showed in a huge study was that chronic opioid patients that got testosterone replacement actually had lower all-cause mortality. Really an amazing study. If you get a chance, you should look that one up. And it interestingly decreased all other adverse health outcomes. They had lower risk of stroke and heart disease, and again, just did much better, much less fractures.
But I don't think this is a reason to keep people on chronic opioids if they don't actually really need them, and just give them testosterone. It's obviously it's a risk benefit of the opioid first.
Yep. And again, if you're on testosterone, you're more likely to have obesity, hyperlipidemia, hypertension. Yeah, are there risks? But compared to not being on it, again, all-cause mortality improves with the testosterone.
I did put this women picture in here just to remind us that even this can happen to women. Low testosterone with chronic opioid therapy. It's a lot harder to give them testosterone to get it covered if they're on chronic opioids. A lot more side effects if you have to give women testosterone because of their chronic opioids. But again, the chronic opioids do have a lot of complications of women, including the biggest one, which is that osteoporosis.
Do you want to speak?
Sure. Kind of talked about this. I loved this study that I found about the impact of opioids on sleep. And you can see, so the top one is a normal hypnogram. Took me forever to figure out how to say that word. So that's a normal, REM sleep, deep sleep, all of that normal sleep hypnogram. Person on morphine, you can see that second one, there's no deep sleep there. There's very little REM sleep. It's just a lot of when you're not getting that restfulness. So you are definitely going to have, fatigue issues and sleep issues. People are going to complain if that's what their hypnogram looks like. They have decreased sleep time and efficiency, decreased REM. If they get naloxone, it goes back to normal. So not that you should give everyone Narcan and put them in withdrawal before bedtime, but it does show that it does get better with cessation or when the active medication is not there.
A few other things just to kind of remind people as we finish up here. Again, the risk of opioids, decreased respirations, pneumonia, again, that immunocompromised person, COPD exacerbations, again, sleep apnea we talked about. Some of the things we have to always think about too is as we send people to into operations, this post-operative time, be very careful with the benzos and opioids together. There's many studies that showed increased mortality in people on both post-op. And again, the long-acting opioids post-op tend to be associated with increased mortality as well as people leave the hospital. Be careful of the patients who are on methadone coming out post-op. Remember, the QT prolongation. And again, this is one disproportionately methadone is linked to overdose death. Again, codeine, one of the interesting things about codeine, and I'll just mention this, codeine, there are fast metabolizers and slow metabolizers. You're going to run into a fast metabolizer sometime when they convert it to morphine and the overdose on codeine. It's rare, but it occurs. But watch the codeine thing. Tramadol, you got to be a little bit careful with post-operative because of the renal, especially renal insufficiency and people with history of seizures. Demerol people don't use anymore. I don't even know if that's around, but that's we kind of listed that.
This is just, at the beginning, we only talked about, the impact of mixing chronic opioids with mental health, with depression, but opioid addiction, opioid use disorder, chronic opioids do impact all these other mental health things, whether it's that is their new coping mechanism, so they're not getting, things addressed, or it's creating more life disturbances. They're not taking their medication. So it's just something to always be aware of, that whether they're on opioids and it looks like one of these, or these are getting covered by their opioids, just never a bad idea to keep these in mind.
And there you go.
All right, so we can take more questions. We've alluded to it. We do have a podcast that has a lot of talks on it. That goes way back. We'll try to do updates on ECHOS or on the Twitter as far as what our upcoming talks. Stratus does as well. MAFP does as well. So there's a lot of resources out there for that. I don't know if tramadol, that's a good one. I'll write that down. I don't know if someone from the MAFP or Stratus wants to talk about getting credits from today or how that process is going to work.
Thanks, Heather. Yeah, this is Christy from Stratus. So in the link, Kendra will be putting in a link that you can fill out for an evaluation. And once you fill that out, within a couple of weeks, you will be getting your CME certificate. We'll also be sending an email out to all the participants after this with the link. So you'll have the opportunity to complete that for CMEs.
Perfect. So next week, the urine drug screens. Again,
2 weeks.
2 weeks. I keep thinking it's every week. 2 weeks, the urine drug screens. If you have any interesting questions or patients with that, it's one of our favorite things to talk about is urine. So we love that talk and all the interesting ways things show up. So yeah.
You will get with the links coming up probably in the next week or two, the thing you can fill out to submit patient cases. So then we can start doing these patient presentations in 2 weeks. If no one's comfortable with that, we'll probably do a canned one, but it's really part of this learning through Project ECHO is these case-based things, because that's real life patients. It's not just the boring didactic.
All right. Well, thank you everybody for coming today. I hope that was useful. We'll see you in a couple of weeks and we'll do this again.
And questions, David, did you have a question?
Nope, but thanks very much.
Thank you.
All right. Have a good day, everybody.